Excellent.
And we are recording. It is all yours.
All right. So let me welcome you all to the University of Montana's School of Public and Community Health Science Seminar, which is co-sponsored by the Global Public Health Program and the Institute for Health and Humanities. I'm Carrie Harris. I'm the Professor of Public Health, and it's my pleasure to introduce to you our speaker for today, Maja Pederson. So Maja is a PhD candidate in public health at the University of Montana's School of Public and Community Health Sciences. She holds undergraduate degrees in physical education and Scandinavian studies, an interesting combination, from Pacific Lutheran University, and a Master's of Science degree in Health and Human Performance from the University of Montana under the mentorship of our very own Dr. Brown. It's been a very busy last year in the PhD program for Maja, and I just wanted to name a few of her accomplishments from this last year. She was awarded a pre-doctoral to postdoctoral fellowship from the National Cancer Institute, the highest award that can be earned at her level. She published the first of 3 manuscripts from her dissertation in a top journal, and she accepted a postdoctoral fellowship at Stanford University. And also she bought a house. She's been very busy. Today, Maja will be presenting her dissertation research titled Promoting Physical Activity Among American Indian Older Adults. And with that, I welcome Maja.
Thanks so much, Carrie. I'm gonna share my screen here and then make sure I'm doing it right. So first I do this. And then I'm gonna switch. Okay, so Carrie, can you just confirm with me that you're seeing the PowerPoint screen and not the presenter screen?
I see the PowerPoint screen.
All right. Okay, first success. Thank you, Carrie, for the kind introduction. I'm Maja Pederson, as Carrie said, and I'm here to present my dissertation research, and I'm super excited to be here today and to share this with you. So first, in gratitude, I'd like to acknowledge that the University of Montana is on the traditional territories of the Salish and Kalispel people. Today, we honor the path they have always shown us in caring for this place and the generations to come. Next, I'd like to acknowledge my dissertation committee members, Dr. Carrie Harris, who's been this excellent chair for me for the last many years, Dr. Curtis Noonan and Dr. Blakely Brown at the University of Montana, Dr. Jordan Lewis, who's at the University of Minnesota in Duluth, and Dr. Keith Anderson, who's at the University of Texas in Arlington. And I'd also like to acknowledge a really valuable mentor and previous committee member of mine, Dr. Gita Swaney. Finally, I'd like to acknowledge my lifelong committee members, Grace Pedersen and Svera Pedersen, who are my parents here today, and thank you for supporting my love of inquiry and communication throughout my life. As you'll find, this is a community-based research project, so none of this research that I'm going to be talking about today would have happened without this amazing community partnership that the University of Montana, or our research team at the University of Montana, has developed with the Confederated Salish and Kootenai tribes. You'll also see CSKT as the acronym there, Tribal Health Department. And this is a partnership with the Community Health Division there. And I'd like to acknowledge Chelsea Kleinmeyer and Ashley Glass, who are in that Community Health Division at CSKT Tribal Health. I'd also like to acknowledge Matea Grant, who I know is here. She's been our awesome research assistant and community liaison for the Flathead Reservation and the CSKT tribes. Nikki Graham, who's been our community research navigator. I'd also like to acknowledge our community advisory board members. We have an advisory board of 10 members who are all American Indian residents of the Flathead Reservation who help to represent the community and provide input based on community perspectives to this research. And then lastly, I'd like to acknowledge research mentors who have been a part of this throughout the last several years, Dr. Diane King at the University of Alaska Anchorage and Dr. Rebecca Lee at Arizona State University. Finally, acknowledging funding. We've been funded since 2018 by the American Indian Alaska Native Clinical and Translational Research Program, and as Carrie mentioned, through an NCI fellowship. So let's get started. What are we going to do today? I'm going to tell you an introduction and background to my research area. And then I'm going to present 3 specific studies that comprise this dissertation research. Talk about how what we found throughout these studies fits in with the current research relevance, and talk about some future directions. Then we'll conclude with some time for questions. So just to get started, I always like to orient everyone to the broad areas where this research is situated. And this is really at this nexus of health equity, disease and death outcomes, or morbidity and mortality, and modifiable risk factors that are shaped by health behavior. So what do I mean by health equity? Well, health equity is when all members of a population have the opportunity to achieve their full health potential, and no one is prevented or disadvantaged in attaining this potential based on social characteristics. Health inequities, or oftentimes called health disparities on the other side, are these preventable differences in the burden of disease, death, or in opportunities to achieve optimal health. And in the US, these preventable differences tend to fall across, among others, ethnic and racial lines. And this is especially true among older adult populations. Now, it's critical to point out here that these preventable differences, both in outcomes and in risk factors and behaviors, are directly related to myriad social and economic forces at work. And oftentimes these are rooted in issues such as historical oppression, colonizing practices and resource dispossession, structural racism, and discriminatory practices across settings from education to employment to healthcare. So there are these broad roots that have an impact on these outcomes. And we see health inequities play out not only in health outcomes, but also in these modifiable risk factors that predispose populations to these outcomes. And these modifiable risk factors, you might have heard of these also as called lifestyle factors. And some examples, some common examples would be like nutrition, substance use, tobacco, and physical activity. So this study orientation focuses on preventive strategies, such as interventions to modify these risk factors and think about health behavior and how health behavior can modify these risk factors. And this area of work is really at the forefront of public health efforts to achieve health equity among such groups. So we'll think about the modifiable risk factor. The modifiable risk factor we're focusing on today is physical activity. And physical activity, you'll also see it as PA. Physical activity is defined as any movement that engages skeletal muscles and requires more energy and expenditure than does rest. This may include a variety of activities. We're going to focus on walking today, but we also open it up within our research to think about other activities aside from walking. So physical activity is a powerful protective factor. It's known to reduce risk for chronic disease, especially leading causes of chronic disease and death, such as cardiovascular disease, cancers, and type 2 diabetes. And specifically for this population that we're discussing today, physical activity is known to mitigate negative effects of pre-existing chronic disease, pre-existing mobility disability, and have protective factors even among populations that have previously been sedentary. So this is really important to note among older adult populations. There are many acceptable forms of physical activity across age groups, but particularly among older adults, walking has been shown to be a popular, common, and accessible form of physical activity. It's also known as a healthful form of physical activity, as it's a way to achieve moderate intensity physical activity, which is associated with many of these positive health outcomes. And then finally, physical activity is a fantastic modifiable risk factor to address because there are effective interventions that currently exist to promote physical activity across a variety of age groups and among older adults. And so we know that there are these interventions that already exist, but unfortunately, many of them have been tested and the evidence has been established among younger populations or populations that are predominantly non-Hispanic white. And so therein lies this gap of research where we know physical activity is important, we know these interventions exist, but they have yet to be applied to populations who may need them the most in respect to health equity. So now we'll move to talking about the study population. This is American Indian older adults, and deviating from common standards for older adults where we think of 65 years and above, we're using the age category or the age criterion of 50 years and above, following precedent exemplary research that follows this evidence that the chronological pace of aging among American Indians may exceed that of other racial and ethnic groups. So we're considering older adults today to be 50 years and above in this population. One powerful indicator thinking about health equity among the study population is this indicator that the life expectancy of American Indians is 5.5 years lower than all US races combined. We also know that these leading causes of death, such as cardiovascular disease, cancers, type 2 diabetes, are disproportionately present among this population. Like other aging groups, this population is growing, so we know that they're estimated to triple by the year 2050. But unlike many other aging groups, this population is known to live in rural areas. At least 44% of American Indians live in rural areas in the United States. And that population, as age increases, is more likely to live in rural areas. We also know that the study population, over half, does not meet federally recommended requirements for physical activity and health, and that physical activity decreases with age. Finally, and possibly very important to this research, we know that there's this recent body of evidence among Indigenous older adults that have reported these themes of optimism, resilience, and really an interest in getting involved in health research to contribute to the health of future generations in their communities. And so thus that really underscores this importance of including their voices and their perspectives in conversations about public health. So the overall purpose of this study package that I'm going to talk about is to reveal the current state of physical activity intervention research among the study population in the US, and then to utilize best practices to identify factors that can influence the development, adaptation, and implementation of interventions to increase physical activity. And here's a simple graphic just to illustrate this recommended progression for development of behavioral intervention research among new populations and new practice settings. You'll see that study 1, 2, and 3 build upon one another in terms of this evidence, and also that along all 3 studies and beyond, as I'll talk about later, we use this community-based participatory research approach, which I'll talk about next. And this slide tends to be a little slow, so bear with me as I pop up some of my pictures here. So this study used community-based participatory research approach. You'll also see this as CBPR throughout the presentation. CBPR is an approach that's recommended for research among American Indian older adults, and it emphasizes, and many other communities, but specifically also among this population. And it really emphasizes principles of social change and community empowerment. The methods that are used along with this approach are designed to help elevate community voice, facilitate shared leadership, and ownership of the research with communities. And this approach is also known to improve the overall quality of research with communities and result in more action-oriented outcomes. So as I mentioned earlier, we've had a partnership with Tribal Health at the CSKT since 2018. Here's a picture of our cool research team. Here are some other pictures just to show you what CBPR looks like for us in practice, because I know there's a variety of ways that we can do CBPR. Over on the left here, you'll see a picture of our team. This is our research team doing data analysis, where we all got together, did a mind meld of the data that we had all looked at separately, and then brought together themes so that we all understand that our voices are equally heard and we can discuss and share perspectives in this collaborative process for data analysis. At the bottom here, you'll see a picture of one of our community advisory board meetings, where we bring together regularly our community advisory board members of the Flathead Reservation communities, and they provide insight and perspectives and help us make decisions about research methods to make sure that our research is relevant and useful and appropriate for their communities. So that gets into this kind of elevating voices of community members. In the middle here, you'll see a picture of an Adobe Sparks page that we used for community dissemination practices. And then these pictures help to represent some more formal aspects of CBPR that we've used. One is a memorandum of agreement that we developed between the University of Montana and the CSKT Tribal Health Department. That was developed in consultation with our legal teams and signed so that we understand that the power dynamic, we understand what our roles, responsibilities, and attempt to have this kind of equitable power dynamic between a community-based partner and an academic institution. At the bottom, you'll see institutional review board approval for our research by the Salish Kootenai College, which is the tribal IRB for the Flathead Reservation. So it's really important that we make sure that our research is approved, our methods are sound for this community and being overseen by the IRB, that's the tribal IRB for these communities. Here's another picture of us being together doing collaborative research. A couple of pictures of us being active together, because if we're going to sit around and talk about physical activity all day, then we might as well also do it together. And especially a really exciting time this summer when the team taught me how to paddleboard, which was pretty exciting. And then finally here over on the right, here's a picture of us during times of COVID presenting to tribal council, to the governing body of this sovereign nation, sharing our research methods, sharing the results, and making sure they're approved by this body. And then at the bottom here, just we pivoted this year. We couldn't go to health fairs the way we normally would to disseminate information. So we joined a virtual health fair for tribal health and shared information about physical activity. So not only doing research, but also being involved in community efforts. So now we'll switch gears and talk about study one. Study one is probably the least CBPR oriented study of the three, but this was a necessary study after we identified within the community that physical activity among older adults, which are rural American Indian older adults living on this reservation, was an issue. There weren't the resources, or possibly there wasn't the engagement that tribal health would have hoped for older adults in these communities. We wanted to see, okay, well then what is the state of the literature for physical activity interventions among American Indian older adults? And you'll see here that we also included Alaska Native older adults in our study search. That's because much of the epidemiological data groups American Indian and Alaska Natives together. And so in order to do a systematic review of the literature, we included both populations to make sure we got the full scope. And the methods that we used were in line with the PRISMA protocols for systematic reviews. And here's just a brief overview of our PRISMA flow diagram. We searched PubMed, Web of Science, and PsycInfo to identify studies that fit our eligibility criteria. And those eligibility criteria included things like being a peer-reviewed original research article, published in English, taking place in the United States, using that age criterion of 50 years or above, or a study sample mean of 55 years or above. We included individual and community level interventions, experimental or quasi-experimental interventions, but all studies needed to have a physical activity related outcome that was both measured and reported. And a physical activity related outcome could have been self-report, or it could have been objective physical activity level. It could have also been more behavioral aspects related to physical activity, like self-efficacy or social support of physical activity. So we originally identified 295 studies that could potentially be included. After reviewing those studies against our eligibility criteria, we identified 23 for full text review. And of those 23, there were 3 that fit our eligibility criteria. And here's just a quick overview of these 3 published studies. As you might note, these studies were conducted over 10 years ago. All of them used samples of American Indian older adult populations, and all of them were out of urban health clinics, so urban settings. The design varied from quasi-experimental to group controlled to 2 randomized controlled trials using pedometers or objective forms of physical activity measurement. And all 3 studies reported promising results in terms of increased physical activity among the study sample. They also reported promising results for other indicators such as psychosocial health, mental health, and social factors related to physical activity. And so there were really these kind of promising findings amidst these studies. However, we noted using the quality assessment tool that we applied to each of the studies that they were all of low or moderate quality. We also noted that there were no community-based practices that were reported across these studies. So this was a concern, as using community-based strategies like the CBPR approach that I mentioned earlier is a recommended practice for use with research among American Indian and Alaska Native communities. So some of the findings and relevance from this study that helped us to understand the state of the evidence for our research area was that despite these broad calls for this public health effort to increase physical activity among diverse aging groups, evidence is scarce in research in this area among American Indian older adults and non-existent among rural American Indian older adults. Also, community engaged strategies have yet to be either applied or reported within these studies. And finally, just given the state of this research, formative research efforts may serve to strengthen the relevance, acceptability, and impact of physical activity interventions among American Indian older adults as they would be a new population, a new study population within this evidence base. And if you'd like to read more on this study, you can find our recently published paper in the Gerontologist. So I'm going to move on to studies 2 and 3. I'm going to present the methods and the participant characteristics of these 2 studies together because we collected data for these 2 studies at the same time. And then I'm going to piece them apart and talk about the theoretical frameworks, the results and findings separately. So for studies 2 and 3, we used qualitative semi-structured interviews to collect this kind of rich data on contextual and cultural factors among rural American Indian older adults. The eligibility criteria that we used to recruit participants was age 50 years and above, identifying as American Indian, and community dwelling residents of the Flathead Reservation. And I actually don't know if I pointed out earlier that the Flathead Reservation is the reservation where the CSKT tribes are situated. So just to make that connection in case that wasn't clear. For recruitment practices, we used an active approach and community-based strategies for recruitment. We presented this study and offered opportunities to sign up at health fairs, at flu shot clinics, at the elders committee meetings, at culture committee meetings. And we also used our community advisory board members, most of whom are older adults themselves, to help spread the word via word of mouth in their communities. We used purposive and snowball sampling methods. And purposive sampling methods we used specifically so that we could make sure we were getting both men and women representation from both men and women, and then also across age groups, because as you might have noted, ages 50 and above is a really big age group. And so we really wanted to make sure that we were identifying participants who weren't all just like 55 years old. We wanted to make sure we were getting people in 60s, 70s, 80s and above if we could. So that was our reasoning behind that strategy. In terms of interview procedures, we followed recommended practices for qualitative research with Indigenous older adults. And some of those were developing a conversational moderator's guide that was respectful and appropriate. And we helped to establish that through a collaborative process of that moderator's guide, going through our community advisory board and also piloting that moderator's guide with 3 American Indian older adults. We selected locations that would not present transportation barriers to the participants. So that looked like we came to them to meet at tribal health clinics that were within their own home communities, or we went to other community centers that they were already going to be at for a different reason to meet them for interviews, or we went to homes or offices. So we really didn't want transportation to be a barrier. We also offered incentives. We offered a $35 incentive for participation in the interview, and we also provided water and snacks throughout because some of these interviews were really long. We used an informed consent process that included both a verbal orientation to the informed consent and a written component. And I should note that the informed consents were signed before any data was collected with all participants. We also were aware of health literacy levels across a range of health literacy for our informed consent process. So we made sure to have a Flesch-Kincaid score of below 7 for those consent forms. In terms of data collection, we used REDCap, which is an electronic data management system to collect demographic and health information. And then we used a digital audio recording process to record the interviews. When it came to data analysis, the audio recordings were transcribed, and those transcriptions were used for the data analysis process. As I mentioned before, this was a collaborative, iterative process, meaning that there was input from all study team members, and we went back to the community advisory board with this information to make sure that we were on the right track. We performed content analysis on the transcripts, and this form of analysis is useful when the qualitative research has been informed by theory. So for these two different studies, you'll note that there are these two different theoretical frameworks we used, and we allowed for both the theoretical frameworks to inform this content analysis, but we also allowed for emergent themes to inform the analysis process. So if there were themes that came up that didn't fit within the theoretical frameworks, we also included those to make sure that we were achieving the full scope of the themes that arose in the data. We also used strategies such as reflexivity within our analysis process. So what that looked like was our all the study team members, the 4 of us who read all the transcripts and did the analysis, we took notes on how our positionality impacted our analysis process across all the transcripts. So we took notes on themes that we saw arise, we took notes on biases or perspectives that we had so that we could better understand how we as researchers related to this qualitative research. This also came up because we included an approach of including Indigenous worldview perspectives into our qualitative analysis as recommended by Simons and Christopher. And what that looked like was there were 4 of us who did these who were participating in this analysis process. 2 of us are European Caucasian descent, 2 identified as Indigenous women. So for the Indigenous participants or their Indigenous researchers, we really asked them to identify and to share how their Indigenous worldview may be impacting the way that they read these transcripts, or maybe impacting the way they saw different themes arise, or how those themes might have connected or connect to other themes or codes within the data. And we really wanted to elevate that worldview, knowing that these data had come from Indigenous participants. And so that was part of the reflexivity process as well. We established trustworthiness within our data using a few different strategies. One was member checking with our community advisory board. Another was using an intercoder reliability process that allowed us to establish a Cohen's kappa statistic of 0.8, which is an appropriate level for demonstrating reliability across coders using our coding scheme. So here are some participant characteristics of who we were able to include in this study. We had 21 overall rural American Indian older adults representing 7 communities across the Flathead Reservation. So we had a good geographic representation. The mean age was 66 years and the range was 50 to 82. So we were able to achieve participants across the age spectrum. As you'll see here, around half, a little over half were female, around half married, half retired or not working, high education levels among the sample. And then also notably, almost 30% had children under the age of 18 living in their homes. And that ranged from 1 child living in their home to 6 children under the age of 18 living in their homes. You'll also see some health characteristics here. I'll point out that what's not mentioned here is that 95% of our participants reported comorbidity, which is 2 or more chronic conditions. And this is consonant with evidence of high comorbidity rates among this population. And it also allowed us to understand that the perspectives we received regarding physical activity, participation, and program recommendations were really informed by a population that experiences chronic disease and that may have these predisposition towards challenges in terms of physical activity, but also in great need of improving this modifiable risk factor. So now I'll piece these two studies apart. Study 2 was really this examination of physical activity behavior among this population. And the theoretical framework that we used is called the ecological model of health behavior. And ecological models examine people's interactions with their socio-cultural and physical surroundings, and are considered a useful framework for the development of public health interventions. One reason why they're useful is because they can address individual level behavior and these broader social, environmental, and political forces that may also impact behavior within a population, Although the ecological model is a Western-based framework, it has been utilized in equity-focused public health and intervention research among Indigenous populations and has been considered to be consonant among these populations due to this understanding that it moves away from a focus that the onus of health behavior is only on the individual or participant characteristics, and thinks about these broader social and environmental forces that also interact with the individual health behavior to form and influence these risk factors. So some examples of questions that we asked in this section of the interview was broadly, tell me about the role of physical activity or walking for health and well-being in your life. Another one that really focused on that social aspect, how do people around you influence how much you participate in physical activity? And another, what gets in the way of walking more often or being more physically active? And so you'll see here this table of study results. Don't worry, I'm not going to go over every bullet point, but I will point out that we were able to identify both barriers and facilitators across individual social and environmental levels. And we wanted to use both barriers and facilitators because although barriers are useful for identifying gaps or needs, we also wanted to move away from this deficit-oriented approach to thinking about public health and instead also focus on these facilitators, or in other words, what things are motivating already, what things are going well at a social or environmental level that we can build upon, what kind of infrastructure already exists that we can build upon within a community that are already strengths. And so we were able to gain data from both. And I'll give you a few examples of quotes from some of these. So one personal facilitator, individual facilitator, was this personal connection to land and ancestors. And one person said, physical activity is important to me. I used to love to hike because I felt like I could connect with my ancestors. I always thought about my ancestors and how they navigated and went over mountain passes and all that a long time ago. I prefer being outside and connected to Mother Earth. Another example of a barrier was a social level barrier of physical inactivity as a social norm. And one person said, most of the time, I never see anybody my age walking around. And then a final example, another social facilitator, which was this value of multi-generational physical activity and inclusiveness. One person said, I think everybody should do it. This is about physical activity. I don't care what size, what age, what anything. And another participant said, we're all somehow connected. And if it means just walking with your grandma down to get the mail or whatever that is together, I think it's really good. So in terms of study 2 findings, participants identified these unique and locally relevant issues. I will point out that many of the issues that arose as themes and were presented in that previous box or that previous table did overlap with other themes of other aging groups across racial and ethnic lines. There were also some very unique themes that came out from this, from these data. And one of those was safety issues, whether that related to wildlife, which could be a result of this very rural geographic setting, but also particularly among the women participants mentioned a concern about violence or getting kidnapped during physical activity. And so that just really helped bring home this concept of physical activity being possibly related to missing and murdered Indigenous women issues as well. Also, this value of land-based activities and how these land-based, culture-based activities related to physical activity. Caregiving responsibilities, as noted, many of the participants were grandparents caring for grandchildren, and this was something that was a concern and also a motivator for many participants. Also, this mental health concept that was very closely related to physical health and physical activity as being a motivator to improve mental health. Those are some unique themes. Also, the ecological framework really helped to reveal some valuable social and environmental factors. And this was really brought home to our research team recently when we were presenting these results to Tribal Council, and the chairwoman of Tribal Council asked the question, I noticed that there were these environmental factors like policies or community leadership initiatives that were identified as missing within our community, and the older adults might not feel supported. So what are some things that we can do from a leadership perspective, whether it be policies or initiatives, to help improve this sentiment of support within our communities? So that just really brought home the value of thinking about social and environmental influences instead of just individual. And then finally, that these findings can be used to support age-specific strategies for future intervention research. Study 3, in contrast to thinking about physical activity behavior in study 2, now we move into thinking about cultural and contextual factors existing within a community that impact intervention preferences among this population. So at the very beginning of the study, I mentioned that there are these existing interventions that are evidence-based, but they have not been applied within this setting. So we wanted to learn, how can we best take those existing interventions and modify them to be more useful within this setting? So here we are. This is a model by Ivanich and colleagues that was specifically developed for this exact situation where we have this evidence-based intervention, or EBP, evidence-based program, as you see it in this model. And if it looks blurry to you, don't worry, you don't need to adjust your glasses. It is blurry, but I wanted to show it to you. And this is this iterative adaptation process where we start off with thinking about this decision to adapt and selecting a close fit evidence-based program that can be used within this community, and then utilizing information gained from the community to adapt and implement this type of an intervention. And so these two arrows represent where we are, where this research piece was done. We wanted to be able to gain information so that we could make an informed selection of an evidence-based intervention, and then also know how we could best adapt it. So in order to gain this information, we used this theoretical framework called the adaptome by Chambers and Norton. And this theoretical framework allows us to think about what parts of an intervention can be modified. We don't modify the core components, or otherwise known as like the active ingredients of an intervention, because we want it to retain its effectiveness. But these are some places where we can modify an intervention. So thinking about target audience, thinking about mode of delivery, and cultural adaptations. Service setting adaptations is also on there, but we know that we're going to be running this intervention through the tribal health department. So we really didn't ask many questions about that. But some example questions that we did ask are, if we developed a walking program for older adults in your community, where should it be located? How structured should it be? How would you want to learn about it? We also asked questions specifically about young people and intergenerational interaction. This was because within the literature, it's shown that within public health efforts among Indigenous older adults, these intergenerational interactions and interactions with youth really have been a focal point. And this was also a local priority for the tribal health department. So we asked questions like, if young people were involved in the walking program, what topics would you like to share while walking? So I'm only going to share summarized themes because the full results have not yet gone through the full community review process, but we were able to identify these themes within a target audience, mode of delivery, and cultural adaptations. And I'll give you a few examples. One is in scheduling specifically for the target audience. And one person said, Maybe if you were to do it around something that's already in place. So like we have senior citizen meals. And if you could do like a walk before or after those meals, because they're already out, it might kind of encourage those accustomed. That happens every week on these certain days, so that we'd help with the socializing and normalizing of fitness. So that was a really cool recommendation. And we received recommendations such as that across other participants. So that was really helpful for us to understand that there are these, what can we build on in the community? And that's an example for local impact. We also asked questions about the physical activity characteristics, like duration, intensity, what type of physical activity, etc. One person said, I like the idea of an organized group, but I wouldn't be able to participate if it was very rigorous. They're going to go on a hike that's 2 or 3 miles. I can't do that. Something that's just local and low key for me. So that really helped to bring in this understanding of inclusiveness and a variety of exercise opportunities. And then finally, intergenerational interaction. This came across as a theme, and one person said, these things that the older people know, the elders, I guess you could say, coming from a tribal standpoint, the elders have all this knowledge. The thing is getting the people to want to know it. But if you can get everybody involved, I enjoy learning. And if I can combine that with physical activity, that makes it even more interesting to me. So what are some of the findings and relevance of this study? Themes really represented this focus on social support, inclusiveness, and specific pathways for recruitment. And those will help us to identify a useful and relevant intervention for this population, and also strategies to recruit participants. These contextual and cultural factors we identified, again, will be used to help with not only the selection of an intervention, but also of implementation strategies within this population, within this practice setting. And then finally, these findings can be applied to a range of physical activity promotion efforts among this population. And this is where I'll explain that this study deviates a little from previous research that's been done to do adaptation implementation among specific communities or specific practice settings, because oftentimes that research is presented as this intervention was already selected and this is how we adapted it and this is how we implemented it. The way we collected our data is that it can inform which interventions to select or which strategies to use, and also can inform this implementation and adaptation process. So we chose this kind of upstream approach that may be able to have broader impact across selection of interventions within this community. And here's the citation for this paper that's now going through community review at the tribes, and hopefully we'll be able to submit it next month. So getting in here towards the end, I know I'm at 40 minutes, I just got 2 more slides, so here we go. I do want to present the limitations of this research. Obviously, there are many. I'm going to present a few. Within the systematic review was observational in nature. There were also a small number of studies, and the study quality ratings were relatively low. So thinking about the outcomes and how reliable or how important those outcomes might be. However, it also has helped us to identify this kind of state of the science, that there are a few studies, and their studies thus far do have relatively low quality ratings. Another limitation for the systematic review is that we only included published research studies. And what we know, especially among tribal communities, is that there is great work being done across these practice settings that is not included in research, is not published in the research. So we're really hoping to just bring this focus point to this area. And so hopefully we might be able to identify some of these programs that are ongoing across tribal communities and bring those to light within the research setting and evidence base. For the qualitative studies, within the qualitative studies or within this qualitative research approach that we used, sample size is small, 21. However, that sample size does fit within recommended sample sizes for achieving data saturation for our purposes. And then another limitation is this, a limitation in terms of generalizability of this research is the heterogeneity that exists across American Indian tribes, communities, and urban to rural populations. So just understanding that this work was done within one tribal nation, and it was designed so to have local impact within that tribal nation, but we should be careful in applying the conclusions of these studies across other communities and tribes. In terms of the research relevance, getting back to this health equity and physical activity promotion, this research package really creates a starting point and research recommendations for relevant, impactful public health efforts within the realm of physical activity and American Indian populations, American Indian aging populations. And then also this research really focused on featuring the voices and experiences and perspectives of the study population, which has historically not been included in public health research in this area. So we wanted to uplift those voices and elevate those perspectives. And then finally, thinking about the theoretical frameworks that we applied across studies 2 and 3, we did establish that these 2 theoretical frameworks were useful within this population, within this study setting, to identify particularly that ecological model of behavior, thinking about those social and environmental factors, and then also thinking about how we can identify these cultural and contextual factors that will affect adaptation and implementation within intervention research. And also just being able to provide example for future research in this area. We did design this to be very locally impactful, but also we want to serve as a model for how this type of research can be done across other communities. Lastly, just thinking about future directions, building up this little staircase here. Our next directions for our partnership are to select and adapt an evidence-based physical activity intervention, and then to implement it within the community and measure implementation factors, and then think about impact within the community. And as we move along this trajectory, thinking about scaling up and thinking about sustainability and how that might, how we can work to ensure that this program that we select has long-term impact within the community. And then of course, using this CVPR approach across all of those continued future directions. So with that, I'll share my references in case you want to take a snapshot of any of these, but also just know that my email address is here in case you have any questions or want to touch base about any of those references or any other questions or comments for me. And I know I went a little bit over, got super excited, but we have about 5 minutes for questions, I think. So Carrie's going to moderate those. So take it away, Carrie.
Okay, good. Yeah, we'll just take a couple of questions and just go ahead and either type them in the chat or turn your microphone on and ask away. So. There must be one burning question out there among the 60 of you.
Hey, this is Joshua Brown. Can you hear me?
Hey, Joshua.
Hey, I got a
So
question for you. I am curious. So you mentioned, or you showed a slide that mentioned next steps. You talked about selecting and adapting evidence-based physical activity interventions. I was curious, was it going to focus more on program settings or programming, or larger structural barriers facilitators?
Hey, thanks for asking me that question. I have an answer to it. We are thinking about, well, first we are going to select an intervention that's going to be focused on individual level behavior, but incorporating some of those social levels. As you saw in some of that data, the social connectedness and social support really came out as a strong theme. So we're likely going to select an evidence-based intervention that will be rolled out through tribal health that both addresses individual level behavior change and also social level behavior change using the social support model. But we also acknowledge that there are these environmental factors that are that influence behavior. And one of those environmental factors was this infrastructure that exists, like walking paths or fitness centers on the reservation across communities. And so separately, one of the plans that we have for this project is to hold a series of these kind of community engagement activities at these pre-existing places of physical activity infrastructure to gain community input on how we can best improve that infrastructure or make it more accessible for older adults. So yeah, you're right on. We're thinking about addressing kind of in two separate efforts, both that individual social level and also one of those built environment levels.
We'll take one more question if someone has a burning question. Otherwise, we'll end. Any burning questions?
There is one in the chat.
Great. From Jenny Miner, what were some of the challenges you faced in following through with your research? Big question.
Well,
Small answer.
if anyone's heard of COVID-19, I would say that was one of the challenges that we faced. You know, we had originally planned to do an intervention as part of this research, and luckily we were able to collect this qualitative data and do this first part of our research before COVID-19 hit. But we were collecting this data into December 2019, planning for an intervention in the summer of 2020, and that did not happen. So that's one major challenge that I'll mention.
Thank you, Maja, for your presentation today and leading the way for the future PhD students in our program. I just wanted to announce that our seminar speakers next week will feature two of those PhD students, Emily Coyle presenting Patient Safety in Healthcare, Approaches to Addressing a Growing Public Health Issue, and PhD candidate Helen Reset will present Measuring Family Child Engagement and Behavioral Development Among Young Children in One Tribal Nation, a research update. So looking forward to seeing everyone next week.
Thank you, everybody, for coming. So happy to see you all.
Thank you, Maja.